Can improved surveillance of sepsis improve outcomes for children? Does the Medicare's oncology model reduce spending or improve quality of care for patients? What's new in resistant hypertension management? This and much more in today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Friday, March 27th, 2026. I'm Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network, and I'm joined today by JAMA Deputy Editor Dr. Preeti Malani. Hello, Preeti. Let's get started.
Hi, Kirsten. Let's start with a timely investigation by Dr. Rhee and colleagues. Pediatric sepsis is a major source of morbidity and mortality, but population surveillance has often relied on administrative codes that may lack accuracy. These investigators conducted a retrospective cohort study of nearly 4 million children aged 30 days to 17 years across 2 large U.S. electronic health record datasets and 3 secondary datasets to assess the burden of pediatric sepsis in U.S. hospitals using a new Pediatric Sepsis Event, PSE, definition adapted from the 2024 Phoenix criteria designed for scalable EHR-based surveillance. The Pediatric Sepsis Event algorithm was subsequently validated against physician-adjudicated cases. They defined sepsis as presumed infection plus organ dysfunction according to the modified Phoenix criteria. Septic shock required the additional presence of cardiovascular dysfunction. The primary outcomes for this study were sepsis incidence and in-hospital mortality. The authors report that the new EHR-based Pediatric Sepsis Event definition outperformed administrative codes for sepsis with a 70% sensitivity and 93% specificity compared with physician-adjudicated cases. These findings are important since sepsis accounted for nearly 18% of all pediatric hospital deaths in 2022, and incidence and mortality were stable from 2016 to 2022.
The editorial by Dr. Schlappbach and colleagues highlights that new standardized criteria and electronic health record-based surveillance tools for pediatric sepsis enable more accurate tracking of incidence and outcomes, supporting improved benchmarking and quality initiatives. Limitations to these approaches include underestimation of cases, especially milder forms, and sepsis in newborns, and the need for international validation and tailored approaches based on local resources and patient populations. These authors encourage clinicians to interpret surveillance data carefully and ensure efforts are adapted to specific contexts for optimal impact.
Next, let's talk about the study by Dr. Brooks and colleagues. These investigators focused on the Centers for Medicare and Medicaid Services Oncology Care Model, or OCM. This is the first national alternative payment model designed specifically for cancer care and was implemented from 2016 to 2022. The OCM aimed to reduce Medicare spending and improve quality of care for patients receiving chemotherapy, addressing the significant cost and quality challenges in oncology more broadly. The authors used a robust difference in differences design, comparing almost 1.75 million chemotherapy episodes at 202 OCM participating practices with nearly 1.92 million episodes at 534 non-participating comparison practices across the U.S., covering 2 intervals, pre-OCM, which was from 2014 to 2016, and during OCM from 2016 to 2022. The study's outcomes included total Medicare payments per treatment episode, excluding care coordination and incentive bonuses paid to practices, breakdowns by service type, as well as measures of utilization like hospitalizations and emergency department visits, as well as quality, such as guideline-recommended therapies and end-of-life care. The results showed that OCM episodes were associated with a modest reduction in Medicare payments, on average $616 or 2.1% less per episode compared with non-OCM episodes. These savings grew during later years and were most notable in high-risk cancer episodes. There were no significant differences between groups in terms of hospitalization rates, emergency department use, or clinical quality measures, suggesting the model neither improved nor harmed care quality. After factoring in extra payments to practices for care coordination and performance incentives, the cost exceeded reductions in episode spending, and the OCM yielded an estimated net loss to Medicare of $639 million over 6 years.
The editorial by Dr. Parikh and colleagues notes that while the oncology care model generated Medicare spending reductions, net savings were undermined by program costs, and the true impact was masked by aggregating diverse practices. The authors highlight the need for faster evidence dissemination, clearer differentiation of committed participants, and greater initial investment, emphasizing that practice-level strategies must be tailored to resources and patient populations for effective, sustainable, value-based oncology care. Preeti, let's talk about the latest research letters.
In their research letter, Dr. Kishore and colleagues explore how national prescribing patterns for directing-acting antivirals to treat hepatitis C have changed from 2013 to 2025. The authors used cross-sectional data from the Symphony Health Metis database to estimate that a total of 1.3 million treatment courses of direct-acting antivirals were dispensed nationwide during this time period, peaking in 2015 with 185,000 courses before declining to 68,000 courses in 2025. Early on, most patients were older adults with Medicare or commercial insurance, but by 2025, Medicaid covered nearly half of prescriptions, and younger adults, those less than 40 years, made up 29% of treated patients. Prescribing by specialists in gastroenterology and infectious diseases dropped from 66% in 2015 to 28% in 2025. And over time, more treatment occurred in non-metropolitan counties.
Drs. Kang and G examined how early-stage biopharmaceutical innovation has shifted globally from the period of 2015 to 2025. Using data from the Clarivate Cortellis Drug Development Database, they analyzed early-stage drug development programs across discovery, preclinical, and early clinical phases. The annual number of drug development programs increased from a little over 10,000 in 2015 to 19,000 in 2024, with preclinical programs accounting for nearly 2/3 of all these programs. The authors found that while the U.S. remains a leader in early-stage drug originations, its overall share dropped from 48% to 37%, while China's share increased from 8% to 32%. These trends were consistent across drug types and therapeutic areas, with biologics now accounting for more than half of early-stage development, driven by China's growth.
Dr. Padzur and Professor Usdin contributed an editorial to accompany this research letter. They reiterate that China's rapid growth in pharmaceutical innovation is reshaping global drug development and increasing access to new therapies. They also highlighted that this activity introduces regulatory and access challenges. In their view, collaboration and regulatory adaptation, such as large trials conducted across multiple geographic regions and flexible data standards, will be vital to ensure timely, safe, and equitable patient benefits.
JAMA recently published some interesting Viewpoint articles. The first, from Dr. Osterer, discusses how, despite being individually rare, genetic disorders collectively account for a significant share of pediatric illness and healthcare costs. He suggests that advances in diagnostics and therapies call for a new care model, moving genetic disease management from the margins to a central priority within the pediatric healthcare systems, with a focus on early diagnosis, multidisciplinary care, and system-wide integration. There's also a perspective article by Dr. Bartz and colleagues, which highlights gaps in menopausal hormone therapy prescribing and the under-recognized burden of menopausal symptoms. This article explores how recent evidence and the FDA's removal of several black box warnings on hormone therapy for menopause provide an opportunity for clinicians to update care, emphasizing patient-centered approaches, broader education, and improve access to treatment.
And there's a collection of 3 JAMA perspective articles about the U.S. Food and Drug Administration's draft guidance on Bayesian methods. These leading methodologists review the pros and cons of Bayesian methods in clinical trials. Be sure to check these out. All 3 are linked in this episode's show notes. JAMA published a collection of clinical content about resistant hypertension. Dr. Azizi and colleagues contributed a review article that summarizes the diagnosis and management of resistant hypertension, a condition that affects a substantial portion of patients treated for hypertension in the U.S. In the JAMA Clinical Reviews podcast, Dr. Azizi discusses the role that white coat hypertension plays in confirming if a patient has resistant hypertension with JAMA Associate Editor Dr. David Semel. Let's take a listen.
Actually, white coat hypertension is quite common, occurring in about 30 to 40% of patients with apparent resistant hypertension. And this white coat phenomenon refers to a situation where blood pressure is elevated in the office, but normal outside the office. That's why the first step when we are facing a patient with resistant hypertension is to perform an out-of-office blood pressure measurement. This is essential, either using home monitoring or 24-hour ambulatory blood pressure monitoring. And if out-of-office blood pressure is normal, the patient has most likely white coat hypertension rather than true resistant hypertension. If we focus on how to measure correctly home blood pressure, patients should be trained by either the clinician or a nurse on how to correctly use a validated automated device with the correct cuff size.
A related JAMA clinical guideline synopsis by Dr. Johnson and colleagues examines the recent ACC-AHA 2025 guidelines for managing hypertension in adults.
There are 2 more JAMA clinical guideline synopses, these covering sepsis. One for adults by JAMA Associate Editor Dr. Chris Seymour and colleagues, and another for children by JAMA Deputy Editor Dr. Tracy Liu and colleagues. These articles address the 2026 ESICM and SCCM guidelines for adult and pediatric sepsis management. This week also has a patient page that discusses the causes, risk factor evaluation, and prevention of stillbirth, defined as death of a fetus at 20 weeks of gestation or later.
The newest JAMA Plus AI Conversations podcast features JAMA psychiatry author interviews podcast host Dr. John Torres as he joins JAMA Plus AI Associate Editor Dr. Yulin Schwen to discuss risks, data protections, and the clinical safeguards required to ensure responsible AI use. Let's listen to their discussion.
What's interesting about these large language models, this branch of AI, right? It's relatively easy to tell it, pretend to be a therapist, keywords pretend, or act like a therapist, and it'll try really hard. Kind of like a puppy, if you tell it to chase a ball, it'll try really hard. Sometimes it'll get it right. Sometimes it'll run across the street and cause an accident. But the point is, the barriers to entry are very low in the space. And that's exciting. Everyone can almost build a bot. We've seen teams on what was character AI before it was banned building their own chatbots to help each other with probably more limitations than benefits overall. But the point being, when the barriers are so low to developing them, we want to make sure that we have good ways to evaluate them and make sure that they're actually going to be useful. So just because you can do it definitely doesn't mean you should do it, or it's going to be effective, or it's safe.
And as always, there's a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
That's a wrap for this week's JAMA Editor Summary. Thank you, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.